Καλημέρα σας. Να ευχαριστήσω πολύ την Οργανωτική Επιτροπή για τη τιμητική πρόσκληση να συμμετέχω σε αυτή τη διημερίδα, τον κύριο Κοτέα, τον κύριο Λανίτη. Και θα ήθελα να καλωσορίσω τον κύριο Τσούλο Νικόλαο, βιοχημικό διευθύνων σύμβουλο της εταιρείας GENEKOR, ο οποίος θα μας μιλήσει για τις πολυγονιδιακές υπογραφές, τι υποδεικνύουν οι κατευθυντήριες οδηγίες και οι προοπτικές κλινικές μελέτες. Κύριε Τσούλο.
Good evening. My name is Nicholas Choulos, and I'm very happy and honored to be part of this very interesting webinar on breast cancer. And I'm here to talk to you today about the multi-gene assays, to go over the clinical guidelines and the prospective clinical trials and what are recommended for the usage of such assays in management of early stage breast cancer. So what I'm going to go over is the unmet need of personalizing treatment of patients that are hormone receptor positive, HER2 negative, early breast cancer, go over the data of the Oncotype DX recurrence score test, go over the clinical evidence of the test, and also summarize and go over a case presentation. So the reason why we're here discussing about the multi-gene assays is the fact that there was an unmet need in personalizing the treatment of early stage breast cancer patients. And the question is, who do we treat? And the question emerges from the fact that no matter what treatment you see in early stage breast cancer, when it comes to chemotherapy, you see that the benefit, either when we're talking about breast cancer recurrence or even the mortality of breast cancer, never exceeds 10%. So what we're trying to identify is within this absolute benefit, who are the 10 patients that do benefit from chemotherapy and who are the 90 that do not. So our target is to be able to separate those two populations. And in order to do this, we need a robust tool that has also both prognostic and predictive information to share. So what we're trying to eliminate is within the high-risk populations clinically to be able to identify the patients that do not benefit from chemotherapy, and on the other side, among the low-risk, clinically low-risk patients, to identify those patients that actually benefit from the addition of chemotherapy. I'm going to go over the data of Oncotype DX. So the Oncotype DX test is based on a 21-gene assay. We have 16 cancer-related genes and 5 reference genes. And you see that the cancer-related genes are based on the estrogen group, the proliferation group, the HER2 group, in which you see genes that we are very familiar with, like the ER and the PR genes, the Ki67, the HER2, but many others as well, and also the invasion group. At the same time, these are referenced against the reference genes, which are there to normalize the tissue, and all these combined in an algorithm produce the recurrence score, which is a score between 0 and 100. Initially, the importance of the test is based on many validation trials, and I'm going to go over the important ones. So in order to validate the prognostic value of the test, we analyzed the samples from the NSABP14 trial for the node-negative patients and the patients from the TransAttack trial for the node-positive disease. But that's not the core of the test, because that was just half the picture. The rest of the information, which is even more important, is the predictive value of the test. So we were trying to show whether the test can identify patients that have chemotherapy benefit. In order to do this, we analyzed the patients from the NSABP20 trial for the node-negative patients and the SWOG 8814 trial for the node-positive disease. And of course, since it's a necessity to have prospective randomized trials, the TAILOR-X trial was designed for the node-negative patients, and the RxPonder trial was designed and executed for the N1 population, as we will go over shortly. So for the clinical validation of prognosis, as I said, we used a landmark trial, the NSABP-B14 trial, which is the trial that brought to the lives of patients, of breast cancer patients, tamoxifen and endocrine therapy in general. So this trial, just to remind you, randomized patients between placebo and tamoxifen. All these were ER-positive, node-negative patients. And what was initially done for the Oncotype DX test was that the tamoxifen arm was utilized in order to be able to show if we can identify the high risk versus the low risk populations. And of course, that was performed and was very successfully conducted because the patients with a low recurrence score had a very good prognosis, in contrast with the patients with a high recurrence score that had a very poor prognosis. And you see that this was strongly statistically significant, and the p-value was very, very strong, less than 0.001. Now, of course, as I said, that was not enough because we had to give the other half of the picture for the patients, which is, do they benefit from chemotherapy? And just knowing the prognosis, you cannot assume that. So the B20 trial was the trial that brought chemotherapy to the lives of patients, of early stage breast cancer patients. Again, ER-positive, node-negative patients, randomized between receiving chemotherapy, tamoxifen and chemotherapy, or just tamoxifen alone. And what we did is we analyzed those samples for with Oncotype DX, and we were able to stratify the patients based on the chemotherapy benefit, which means that every patient below the score of 25 had no chemotherapy benefit, as you see here among the gray and the pink lines between them. But you see that the patients that had a high recurrence score over 26, those patients had a 26% absolute chemotherapy benefit, which is rare. We rarely see in oncology such a big benefit. So conclusion from this was that we were able predictively to show who benefits and who does not benefit from the addition of chemotherapy. And of course, in order to validate all this, and in order to show that in the in-between zone, which is between 11 and 25, there's no patients that actually show any chemotherapy benefit. So we were trying to show whether the addition of chemotherapy was superior to just endocrine therapy alone. So this is TAILOR-X was designed prospectively with 10,000 patients, looking at whether chemotherapy is a non-inferiority trial. So we're trying to show if endocrine therapy alone was inferior to the addition of chemotherapy. And as a conclusion from this trial, we showed that there's no chemotherapy benefit in that population. So these patients were randomized between receiving chemo and no chemo, and they with a score of 11 to 25. Everybody below the score of 11, so from 0 to 10, they only took endocrine therapy because we had strong data from the B14 and B20 trial that these patients do not benefit from the addition of chemotherapy. On the other end, everybody with a score over 26, they were clearly validated that they actually benefit from chemotherapy, and they all received chemotherapy. So in that score between 11 to 25, there was no benefit from chemotherapy in the from the TAILOR-X trial, and this was with a median follow-up of 7.5 years. Even if we looked at different endpoints like the DRFI or the overall survival, you see that there's no chemotherapy benefit in any one of the endpoints. And also there's no subgroup that actually benefits from chemotherapy besides the subgroup of the age. So even if they had a high grade versus low, or a bigger tumor versus a smaller tumor, or a clinical risk high versus low, there's no chemotherapy benefit. The only place where we saw some chemotherapy benefit was the patients below the age of 50. And we will go into this a little bit more. This population, which was this benefit is concentrated in the population between 40 and 50 years old, which shows us that most likely it has to do with the ovarian function suppression effect of the chemotherapy and not actual chemotherapy directly benefit. But because we don't show this, and we don't see this, excuse me, in the patients below the age of 40, where OFS is more rare. But we'll get back to this after we go through the node positive data as well. Last December, in San Antonio, in the Congress of San Antonio, the updated analysis of the data from the TAILOR-X study were announced and presented. And now we are looking at 11 years follow-up versus the 7.5 years median follow-up that we had before. In the updated analysis, we see that the subgroups, the low versus high, maintain their strong statistical significance in difference. So this stratification remains over time of low versus high. And also the patients with scores between 11 and 25 in all the endpoints, they never showed any difference more than 1%, exactly as they were in the initial 7.5-year time frame that we had the initial follow-up of the study. So this shows also in late recurrences that the data from the test are reliable throughout the this time frame, and we're of course continuing to follow up since the test is trial is designed to have a 20-year follow-up. So we will be following up these patients over time. But for the 11 years median and average 12-year follow-up that we have now, it's very clearly that the low-risk patients remain low risk, and there's no chemo benefit even in that time frame. So late recurrences are also taken into consideration. And as you see here, between the primary analysis and the updated analysis, in all the endpoints, as I just mentioned, there's no statistical significance, and it's always less than 1%, the difference. When we're looking at that subgroup of the 50 years old group that we mentioned before, you see that from 11 to 25, even in the updated analysis, there's no chemotherapy benefit, and there's a marginal benefit from the scores of 16 to 20, which is located, it's identified only in the high clinical risk patients, so patients with a higher grade and a higher size, and everybody over the score of 21 has a substantial evident chemotherapy benefit, which is approximately 8.5%. So you see clearly that this data is very similar to the data that we had from the initial trial. So very confidently, we can say that we're treating the patients the right way based on this test. And we see again that this age group is limited to patients between 40 and 50, and menopausal status is not relevant. So we see it only in the age limit, not the menopausal status limit. And we don't see it in the patients below the age of 40, which shows that most likely it has to do with the ovarian function suppression and not with the actual chemotherapy benefit. But we'll get back to this when we go over the node-positive disease as well. So as a conclusion, as I said, summarizing the node negative, we have data in all the subgroups. We have prospective data from the patients in between 11 and 25. We have long follow-up, so we can confidently cover also the late recurrences. And there's no practical changes in any endpoint in this subgroup. But focusing now on the node-positive disease, initially trying to show the prognosis, we used this landmark trial, the TransAttack trial, which is the trial that brought aromatase inhibitors into patients' lives. And Oncotype was utilized in order to show if we can identify who's at low risk and who's at high risk based on their gene signature. And of course, this was done in a very strongly statistical way, and having patients with a low recurrence score had a very much lower prognosis, lower risk and better prognosis compared to the patient with a high recurrence score, where they had a high risk and a poorer prognosis. And I remind you that these patients are N1 disease, so it's 1 to 3 positive lymph nodes. And of course, that was the prognostic part, so half the picture. The other half of the picture is the predictive part, and we found, we worked with the SWOG team for the SWOG 8814 trial, and these were N1 patients mainly, but there were also patients with N2 disease in this group, and we were they were randomized between getting chemo and no chemo, which is ideal for showing prediction chemotherapy benefit. That's actually the only way to show chemotherapy benefit. So we analyzed the samples, and we showed that the patients in the low recurrence scores had no chemotherapy benefit at all, and the patients in the high recurrence scores had a high chemotherapy benefit, which was statistically significant as well. And this separation started at the score of 25 and above. The curves were able to separate at that point, as you see here. So our exponder was a trial that was designed prospectively in order to validate this data. And what was done is the patients below the age, the score of 25, N1 disease, ER positive, HER2 negative, were all of 5,000 patients had scores between 0 to 25. The whole study had almost over 9,000 patients. So 5,000 of them were with scores between 0 to 25, randomized between endocrine therapy alone and chemotherapy followed by endocrine therapy. And everybody over 26 clearly benefited from chemotherapy from the SWOG trial. So those were, they took the path of chemotherapy. So in December of 2020 at San Antonio, the first data was introduced, were actually presented. And we had a 5.1-year follow-up. And then next year at the New England Journal of Medicine, there was the 5.3-year follow-up, and that was published. And the same year in San Antonio was also 6.1 years data presented. So this is the diagram to show you the inclusion criteria and the evaluation of the patients and the exclusion of some patients. And here's to show that between the two arms, the test was, the trial was balanced between the endocrine arm and the chemoendocrine arm. And the results were as expected, that there's no chemotherapy benefit overall in that group in scores between 0 to 25. So the trial successfully showed that patients with a score below 25 do not benefit from chemotherapy in the invasive disease-free survival, distant recurrence-free survival, and every endpoint we showed the same. When we separated based on menopausal status, we saw that in the postmenopausal patients, this was strong. The data was showing that there's no chemotherapy benefit. And there was no subgroups among the postmenopausal patients that actually had the benefit from chemotherapy, regardless of age, grade, size, clinical risk, even number of lymph nodes, 1 versus 3 or 2 versus 3, even if the recurrence score was below 13 or from 14 to 25, or even the histological subtypes. Nobody showed in that group between 0 to 25 recurrence score that there's a benefit of chemotherapy. So we safely forgo chemotherapy for those patients. On the other side, in the younger premenopausal patients, we saw some benefit of chemotherapy in all the endpoints. And that was clear in the distant recurrence-free interval, which we had 2.5% chemotherapy benefit, and the invasive disease-free survival, that was almost a 5% chemotherapy benefit. And in all endpoints, it was the same throughout in the younger premenopausal population. So you see here that all the subgroups, in contrast with the postmenopausal, here all the subgroups had benefit from chemotherapy. So even if it was 1 lymph node versus 2 or 3, or high versus low clinical risk, everybody had benefit from chemotherapy, regardless of age. As long as they were premenopausal, they had benefit from chemotherapy. So for the node-positive patients, the cut point is menopause, in contrast with the node-negative patients, where the cut point is the age. And even when we looked at micromets versus N1 disease, we saw that even in the micromets, if they're premenopausal patients, those patients benefit from chemotherapy. And this most likely, as I said, is related to the menopause, because the patient that had initially had their periods, and then from the premenopausal, and then became they lost their periods, then you saw that those patients had a smaller probability of IDFS, which is the purple line on your screens, and the same is for both on the endocrine side and the chemo side on the right. So because we saw this effect both in the node-negative patients and the node-positive patients, a new trial is actually being launched currently, the OFFSET trial, which it's premenopausal patients that are ER positive, HER2 negative, N0 or N1, And these patients are all oncotyped and stratified. And if they have a score below 25, they're randomized between OFS and aromatase inhibitors for 5 years, or chemotherapy and OFS and aromatase inhibitors for 5 years. And this will answer to us the question of whether this effect that we see is based on chemotherapy or on the OFS. So just to put everything in a nutshell, when we have HER2 positive, HER2 negative, estrogen receptor positive early stage breast cancer, and we have a node positive patient with a score below 25, then if this patient is over the age of 50, then endocrine therapy is clearly the way to go. This is non-inferior to adding chemotherapy. If this patient is younger than 50 years old, then we see some benefit in the scores between 16 to 25, including incorporating also the clinical risk as we discussed. If this patient, if there's a patient with N1 disease with a score below 25, if they're postmenopausal, then they have no chemotherapy benefit. If they're premenopausal, as we said, then you see a 2.4% benefit in 5 years on the distant recurrence-free interval with the chemotherapy. So there is chemotherapy benefit, 2.5%. And then on the other side, even if it's a node N0 or N1 disease, if the recurrence score is over 25, then there is an increased chemotherapy benefit. And this is what is shown in all the guidelines. The ASCO, as I will show you in the example as we go over it, the ASCO guidelines and the CCN have it as a preferred test that with the highest quality, and then St. Gallen and ESMO are also mentioning this as the decision maker for chemotherapy in those patient populations. So just to go quickly into this case before we end this session, we have a 48-year-old patient with a 1.8 centimeter tumor, premenopausal, invasive ductal carcinoma, ER/PR positive, HER2 negative, grade 2, negative lymph nodes, good general health, and Ki67 of 25. So let's assume that this patient did oncotype, and the recurrence score came back as a 32. So let's see how the guidelines are taking this into consideration. So this patient is, based on the NCCN guidelines, Oncotype DX gives for this patient predictive and prognostic information. So you can choose it for assessing the risk for prognostically, but also predictively to make the decision of chemo or no chemo. And it's a preferred test based on the NCCN guidelines, and it's level of evidence 1, category 1 from the NCCN. So strong data to support your decision-making for this patient. Now, if you go to the ASCO guidelines, you see that it's the only test recommended for premenopausal patients with a patient with node negative disease. The only test recommended by the ASCO guidelines with high quality of evidence and strong strength of recommendation is Oncotype DX. But even if she was a postmenopausal patient, both node negative and node positive, you will see that Oncotype has the strongest level of evidence, and this is actually a screenshot from the ASCO guidelines. Now, if the same patient, remind you, premenopausal, ER/PR positive, HER2 negative, Ki67, 25%, grade 2, negative lymph nodes, did mammoprint, and she came back with a result with a high risk luminal type report, just like this one. Then if you want to assess the chemotherapy use for this patient based on this report, and this is from Agendia's website, you'll see here, because this patient is considered to have a low clinical risk because she has a grade 2 and below 2 centimeter tumor. So she's a low clinical risk patient. So based on mammoprint, this patient would not benefit from chemotherapy. Even if she came back with a high risk test, she should not be using this test in order to assess the chemotherapy benefit, because based on the MINDAC trial, it showed that the clinical low patients, even if they had a high mammoprint score, then there was no chemotherapy benefit for that population, which allows you to undertreat a patient that actually needs chemotherapy. And even if she had, on the other side, a high clinical risk and she came back with a low genomic score, then that patient, being younger than 50 years old, even if she had a low mama print, she would show chemo benefit, which would be completely contradicting with the fact that she came back with a low mama print. So this is to show that a prognostic test has failed to show prediction. So you cannot use a prognostic test like mama print or like EndoPredict, like we'll show you, in order to make decisions of chemotherapy or not. And this is why the NCCN guidelines clearly state that even though it's category 1, because it has a prospective trial, it's not a preferred test. It's prognostic, yes, but when you look under predictive, it says not determined, because it was not able to show through the MINDAC trial who benefits and who does not benefit from chemotherapy. If you look at the ASCO guidelines, you'll see that being a premenopausal, node-negative patients, you should not be using MammaPrint for that population or any other test besides Oncotype DX, and this is from the ASCO guidelines. But even if she was postmenopausal, still the strength of recommendation, the intermediate quality of evidence is what is being said. And it's actually, if you look at the footprint, it says only in patients with high clinical risk. And our patient had a low clinical risk, I remind you, even though Ki67 is very high. So last but not least, this patient, let's say that now the same patient did also the EndoPredict test. And the EndoPredict came back with a high score of 5.8% risk, the EPCLEAN. That shows, based on the report, that this patient has a high benefit of chemotherapy. But where do they base this information? First of all, to have a high risk with a node-negative disease is very rare with the EndoPredict because it's driven by the nodal status. As you see here, the cut point is the red arrow, and you see everybody over the red arrow on the right is mainly yellow and red, which means that they are node positive patients, and most of the node negative patients fall in the low score, the low EPCLEAN. But nonetheless, this chemotherapy benefit that is reported on the report of EndoPredict is based on a pooled analysis. So it's not a randomized trial. It's the combination of 5 different trials where they picked and chose the patients from 3 trials that took only endocrine therapy, irrelevant between them trials, and then 2 other separate trials that for the patients that took chemotherapy, and they combined that. And we know very well in oncology that is not acceptable. And even the publication states clearly that this is a joint analysis, it's indirect comparison, so it's all the phrases that we don't like to hear in oncology from validating. And that's why this has a level of evidence of 4, which is the least level of evidence that you can have. And this is why the NCCN guidelines gave them the category 2A, which is the lowest one. And when it comes to predictiveness, it says not determined because they did not show this in any randomized clinical trial. So you have to be cautious when you use this test on how you select. What do you do with the information that you get? Last but not least, the ASCO guidelines clearly stated not to use this test in the premenopausal node negative population, but even if she was postmenopausal, still it says intermediate quality of evidence and moderate strength of recommendation, so very poor recommendation. So just to sum up, what we're looking for when you are trying to identify which is the right multi-gene assay to use is to see what is the level of evidence, if there are prospective clinical trials, if it is predictive of chemotherapy benefit, so can we make treatment decisions based on it? If it's just prognostic, what is the clinical utility? How can it change my decisions? And as we said before, it's a different thing to use it as a prognostic or a predictive tool. And if it is in the guidelines, and carefully assess this, because they all are in the guidelines, but you have to be aware of how they are part of the guidelines. Are they prognostic only? Are they also predictive? What is the category, the level of evidence? And this is the only way that we can actually do what we always talk about in all the congresses and do it in the clinic, which is evidence-based medicine for each one of the patients in order to tailor and personalize their treatment decisions. Thank you very much for your time.
Να ευχαριστήσουμε πολύ τον κύριο Τσούλο για την εξαιρετική ομιλία του. Πολύ σημαντικό αυτό που μας είπε, ότι στις προημινοπαυσιακές γυναίκες, ακόμα και αν έχουν χαμηλό σκορ, αν έχουν θετικούς λυμφαδένες, θα δώσουμε χημειοθεραπεία. Η ομιλία του ήταν βίντεο, οπότε θα προχωρήσουμε στο επόμενο τραπέζι για την κληρονομικότητα του καρκίνου του μαστού και να δώσω το λόγο στον κύριο Γιαννουκάκο και στην κυρία Κωνσταντοπούλου.